Hi, everyone. Welcome to the Top 5 Things Fit Should Know About series. I am Jordan Jaggers, Vice Chair of the Quad AI Fit Committee. This session of our series is the Top 5 Things Fit Should Know About Asthma and Pregnancy. Our guest presenter is Dr. Natasha Correa. Natasha is a clinical immunology and allergy fellow in training in her final year at the University of Toronto in Toronto, Canada. She completed her medical school at the University of Toronto and internal medicine residency at Western University in London, Ontario. She is currently completing a master's degree in clinical epidemiology at McMaster University. She is also part of the Vaccines and Medications in Pregnancy Surveillance System, or VAMPSS, as the VAMPSS Fit representative and is working on a project on allergy immunotherapy in pregnancy. Welcome, Natasha, and thank you for leading this session. I will turn it over to you to get us started on the top 5 items you have for FITs about asthma and pregnancy.
Great. Hi, Jordan, and thanks so much for having me. So as you mentioned, I will be talking about the 5 things to know about asthma and pregnancy. And I'll be talking on behalf of VAMPSS, or the Vaccines and Medications in Pregnancy Surveillance System. So the first thing FITs should know about asthma and pregnancy is the effect of pregnancy on asthma. So traditionally, studies showed that about a third of pregnant individuals experienced worsening of their asthma symptoms in pregnancy, a third had improvement, and a third had no change in their symptoms. However, more recent work has shown that 40% experienced worsening of their asthma symptoms in pregnancy, and 60% had no change in their symptoms. The largest increase in symptoms begin in the second trimester, and asthma exacerbations are also more common in the second trimester. According to one systematic review and meta-analysis, the risk factors that are associated with exacerbations were severe asthma, Black race, depression, anxiety, and multiparity. Many of these risk factors were also associated with worsening of asthma symptoms in the pregnancy and also included obesity, exacerbations before the pregnancy, and having poorly controlled asthma. The second thing FITs should know about asthma and pregnancy is the effect of asthma on the pregnancy. So asthma in pregnancy is associated with an increased risk of several maternal complications, including gestational diabetes and preeclampsia. Also, poor birth outcomes, including preterm birth, low birth weight, and cesarean delivery, and neonatal complications such as congenital malformations, perinatal mortality, and neonatal hospital admissions. Management of the asthma may improve some of these outcomes. For example, the risk of preterm birth is reduced if asthma is actively managed. The third thing FITs should know about asthma in pregnancy is regarding the monitoring of asthma in the pregnancy. You can use spirometry and pre and post bronchodilator testing in pregnancy since there are minimal changes to your FEV1, your FVC, and your FEV1 over FVC ratio due to the pregnancy itself. However, you may want to avoid methacholine challenge testing in the pregnancy, as pregnancy is a relative contraindication for methacholine challenge. Also, the PC20 value may increase in pregnancy as airways become less hyperresponsive in the pregnancy. And finally, the asthma control test has been validated for use in the pregnancy. The fourth thing FITs should know about asthma and pregnancy is that most reliever and controller medications have good safety data for use in pregnancy. The general principles of stepwise approach to asthma management are the same as in the general population. Short-acting beta agonists are generally safe to use. We have the most data for albuterol. There are small studies that show increased risk of specific congenital malformations, but asthma control and exacerbations are a confounder in these studies. Inhaled corticosteroids are also generally safe to use, especially at low and medium doses. High-dose inhaled corticosteroids have been associated with congenital malformations, but this observation, again, may be confounded by asthma control and severity. And we have the most data for budesonide and fluticasone. Long-acting beta agonists are also likely safe. Data is available for salmeterol and formoterol. There are some reports of increased risk of specific malformations, but again, asthma control and severity is again a confounder. In terms of leukotriene receptor antagonists, we have the most data for montelukast. There is no increased risk of congenital malformations. There's possibly an increased risk of preterm birth, preeclampsia, gestational diabetes, and low birth weight. For long-acting muscarinic antagonists, we have no human data, but there was no congenital malformations in animal studies. And finally, for systemic steroids, you would want to use it if indicated, as the maternal and fetal risk from uncontrolled asthma exceeds the risk of systemic steroids. There have been associated with systemic steroids, congenital malformations, preeclampsia, gestational diabetes, low birth weight, and neonatal adrenal insufficiency. But again, concomitant use of other asthma medications and asthma severity is a confounder. And finally, the last thing FITs should know about asthma and pregnancy is that we have limited data on biologic use in pregnancy. Omalizumab is likely safe as per a registry study, which showed no increased risk of major congenital malformations. For the rest of the biologics, we either have case report data or no human data. There are a couple case reports for benralizumab, with one showing a child that had eosinopenia for 7 months, and one case report for mepolizumab with a healthy child. For dupilumab, we have case report data, all resulted in live births. There was one premature birth and one low birth weight infant, and it was mostly used for atopic dermatitis. There is currently a mother-to-baby registry in progress for dupilumab, and we have no human data for rezolizumab and tezepelumab. So to summarize, about 40% of asthmatics who get pregnant have a worsening of their asthma in the pregnancy. Asthma in pregnancy is associated with an increased risk of adverse perinatal outcomes, but better asthma control during pregnancy can reduce some of these risks. Human data is usually and generally reassuring for most of your asthma medications. So for your short-acting beta agonists, for inhaled corticosteroids, for long-acting beta agonists and leukotriene receptor antagonists. And for biologics, we have safety data, mostly for omalizumab and some case reports for some of the other biologics. And most of the adverse effects that have been reported for asthma therapies is limited by the presence of other confounders in these studies. And finally, the benefits of treating asthma to improve control and reduce exacerbations generally outweigh the risk of possible adverse effects from asthma medications. And that's all I have to say about asthma and pregnancy. Hope that was helpful.
This was so helpful. Thank you for going through all of that information because I'm sure at some point, whether in our training or as an attending, we will definitely have pregnant individuals that we are caring for. And I feel like after listening to this, we can all feel more confident with using medications that they need because really at the end of the day, we need to treat them for best outcomes for patients and the baby. And so thank you for going through all of this. So before signing off, I would like to thank Natasha for volunteering her time. We appreciate the information and guidance you shared for the FITs. If you have any follow-up questions after viewing this session, please reach out to our FIT staff liaison, Mari, at mduran@quadai.org. See you soon. Thank you.
Thank you.